All right, so I'm going to be doing an overview of liver disease and listing criteria. I believe, and Jenna, correct me if I'm wrong, you can write in the chat if you start to have questions and don't want to forget them.
Yeah, I have everybody muted, and you're going to stay muted while Alyssa's talking. But if you have a question, you can send it in the chat during, or at the end of the presentation, I'm going to unmute everybody and you can ask questions at that point too. So it's completely up to you which one you prefer.
Whatever we usually do is fine. All right. So an overview of liver disease and listing criteria. Oh, there we go. So it's just some liver basics. It's the largest glandular organ in the body. And glandular means that it produces things like hormones and cholesterol. It is a reddish brown organ. Hepatocyte is the basic cellular structure of the liver. That's what that word is. It's on the right side, just under your diaphragm, just tucked up under your ribs. So we only have one and it's on the right side. It receives a lot of blood from two large main blood vessels, the hepatic artery and portal vein. Pretty much all the blood in the body has to go through the liver at some point. It does a lot of toxic, take up, it cleans, it puts out things. So the blood has to flow through it for it to do that job. And it's connected to the small intestine by the bile duct. So there's our anatomy. Here's a good drawing of it, like a Gray's Anatomy type drawing from the book. And that red is the liver. The pinkish is the small intestines, and then the large intestine is the yellow, and there's some other organs, I think, tucked up in there. And this is another depiction of it. That green is the gallbladder. The white going through it is the falciform ligament. It separates the right from left lobe. And it holds it in place to some extent too inside the body, because all our organs are suspended essentially and everything's held in place by tissues. So that's one of them. So its functions, as I was saying, it does a lot. And one of them is detoxification. It also has a part in metabolism. It creates things like proteins, hormones. It produces bile, which is why it's connected to the small intestines. It goes into the intestines when we eat. It helps absorb fat and break down things so we can digest. The liver has part in the immune system, protection against infection. It is necessary for survival. It's essentially the heart of the abdomen. The heart's the heart of the thoracic cavity, and this one is the main organ down there. And there's no way to compensate for the absence of liver function, meaning with someone who has kidneys that don't function anymore can get dialysis, but there is no such thing for the liver. And transplantation, this is the definition, the surgical removal of a healthy organ, in this case from the liver, from one person to another. And the new organ can come from someone who is deceased or someone who is living. As we probably all already know, since everyone here is in evaluation, you've probably had this conversation with one of the doctors or one of the nurses, one of the transplant coordinator nurses. So who needs a liver transplant? These are the reasons that would cause us to say that to someone to indicate that they need a liver transplant: cirrhosis, liver failure, liver cancer, and there's other rare diseases that are really most commonly seen. I believe they list them further in this, but they're much more rare than the other things listed here. So cirrhosis is extensive scar tissue, and it can come from damage to the liver over time. All of the diseases listed under cirrhosis cause damage. So alcohol can do that, viruses, autoimmune, which is the body attacking the liver, inherited disorders, some of the more rare ones, and fat in the liver can cause damage over time, causing cirrhosis. Liver failure can happen in a liver that may have previously been functioning just fine, but because of something very fast onset, that can just stop the organ from working completely very quickly. So it would be fulminant liver failure. Some viruses can do that. Hepatitis A, B, autoimmune can do that as well. Wilson's and Tylenol. And then it still says liver cancer and rare orders of metabolism, as we said on the previous slide. And as I was describing, cirrhosis is extensive scarring of the liver. And this is a depiction of what the liver looks like when it has extensive scarring. The liver is a very smooth organ. And once it starts to have damage, it creates scar tissue. And that scar tissue is not very soft and smooth. So it starts to have tougher parts and then smoother parts, and then it starts to become bumpy like this. So you can see that it's trying to show a very bumpy liver here, and that's what cirrhosis ends up looking like. It's all the way through the liver. And this is a depiction of what I'm saying too. So the normal liver there, smooth, pinkish, reddish color. Something is causing inflammation, some sort of damage, and damage over time, over and over and over again, can cause scarring to occur, which comes to cirrhosis. And someone with cirrhosis has a risk of liver cancer, because if you can imagine it, something damages, the body wants to repair, but if something continues to damage, it can't repair it perfectly every time, so it ends up laying down just scar tissue to keep everything together, but it still wants to repair. And cancer is essentially repair gone wrong. So when something that has a lot of places where it's trying to repair itself, and something that might continue to cause damage, it continues to try to repair, one of those times can get out of control and end up with cancer. And this is a good question. The liver can regenerate, and so therefore, why would I need a transplant if it can do that? There is a point where the liver cannot fix itself anymore to be a perfectly functioning liver. When the scar tissue outweighs the functioning liver tissue, that functioning liver tissue is trying to make up for the rest of the organ that's not working anymore. It doesn't have proper, tissue in it. So cirrhosis is not reversible. And even though the liver tries, it cannot fix it to the point where it does not have those problems that it had from having so much cirrhosis to begin with. So in cirrhosis, a person can have a lot of scar tissue and all of the functioning areas can continue to work well, but there is a point sometimes when it no longer does that. So that would be called decompensation. And what we can see in that is all of these problems. So the detoxification part of the liver doesn't work so well anymore, and the blood can continue to accumulate the toxins that should have been gotten out of the body from the liver. It doesn't produce all the things that usually produced to begin with, because it doesn't have enough functioning tissue to do that. And because the liver has these hard parts, and a lot of it, the blood, like I said before, all the blood in the body pretty much has to go through the liver at some point. It causes a buildup of pressure. So it cannot go through it so well and so easily. And then we get something called portal hypertension, because there's high blood pressure right at the liver because it's having a hard time getting through. So the detoxification part is what we would call hepatic encephalopathy. Ammonia specifically is responsible for this. And we treat it with lactulose and rifaximin. There may be some of you who already know these things and know what it feels like and know this treatment. But it causes a lot of confusion, just inability to focus, sometimes sleeping problems. It can cause a lot of things happening that might seem a bit vague, but once they're cleared up, you realize exactly what was causing it. And in part of the detox, the bilirubin, the bile, should be flowing nicely through the liver, but sometimes it does not and gets backed up. And so it's not going to be able to clear it as well because it's already not clearing things well. And then we get a buildup of bilirubin causing jaundice, which is that yellowing of the skin or eyes. There really is no treatment for that. We try to help whatever's causing the problem to begin with. Like if something's inflaming the liver, we try to take that thing away. Sorry, my cat. But there's nothing directly to affect jaundice that we could give someone to clear it up. So we kind of have to wait it out or try to help the thing that may have caused it in the first place. Okay, and this is the decreased production of substances. So there's a lot of things the liver produces and has a part in producing, but some of the main things that we see is a decrease in platelets and a decrease in coagulation. So INR is part of the coagulation and it will go up, which it's the It's a rate of time of how fast a person clots. So if you're not making enough coagulation proteins, then your clotting time will go up. You won't clot as quickly. So INR goes up. Platelets go down, which is also part of clotting. So we kind of have these, differences and things from the normal, and it increases the risk of bleeding to some extent. We do try to prepare for things when we have our own measured way of understanding what could happen to a person, and we might give blood products prior to procedures. The second bullet here, the decreased production of albumin. So albumin's a protein, and it's a protein needed for a lot of processes in the body. When we don't produce enough, then the balance of fluid in the body is off, and it can cause swelling. So the liver's not producing albumin levels go down, and then the swelling can happen, which we call ascites. You can see lower extremity swelling, and we'll get to that too, the ascites. Okay, so this is the portal hypertension. There is, like I was saying, high blood pressure near the liver, but the high blood pressure near the liver makes the body think it's having high blood pressure, and it actually causes the rest of the body to have low blood pressure. So that's always a very interesting thing. You have one system thinking one thing, one system doing another. The changes in pressure, both at the liver and around the body, can cause fluid to come out into the abdomen. So your blood volume has to do with the pressure. And if the volume goes down, then if the volume goes up, then the body thinks it needs to get rid of it to get rid of the pressure. So then we get the fluid leaking out into the abdomen. The other part is that the buildup of pressure at that liver, the portal vein there, causes a buildup of pressure to other vessels around the body. So varices here is the vessels in your throat, the blood vessels that are just inside your throat, can actually become bigger and more prominent and swelling, like varicose vein, because they have a buildup of pressure going to them. And that's dangerous because those can easily bleed. They're right there where something can hurt them and they can bleed. So that's another complication of cirrhosis. The spleen can enlarge because platelets are sequestering theirs, as we say, and that's also part of the decrease in platelets and the coagulation. Sodium changes because of the fluid balance, because wherever water goes, sodium goes too. And then the hepatorenal syndrome and hepatopulmonary syndrome also have to do with that change in the pressures around the liver. So like I was saying, that pressure can build up to other vessels. This starts to happen to those as well, and it changes their function too. The kidneys are very sensitive to changes in blood pressure. So if they have too much coming to them, something happens to them. If they have too little, things can happen to them. So they can get very dysfunctional based on just how much blood is coming to them, how much or how little blood is coming to them. And same thing with the lungs. They're very vascular. So if they have changes in pressure too, then they have issues as well. And then that goes for portal pulmonary syndrome as well. So they're all complications of this higher blood pressure towards the liver because the blood can't flow through it so well because there is all this scar tissue not allowing the blood to go the way it usually would. So this is a picture of ascites. That's a very large ascites. That's a lot of fluid in there. The person may have a little umbilical hernia, so a belly button hernia, and that gets pushed out too because you have all this pressure from all this fluid just, pushing on everything and making everything pop out. One risk of ascites is something called spontaneous bacterial peritonitis, which is an infection of the lining of the abdomen. It can happen spontaneously, hence the name. And it's something that we always look out for. We're always monitoring for a lot of things. So this is always close to our mind if we're seeing someone with ascites. It would take antibiotics to correct it, as one would expect, but then we'd always want to be watching out, making sure it doesn't happen again. And ascites itself, we also always want to try to reduce as much as we can. And we always will recommend low salt diet, low fluid intake as much as possible to keep that balance, because if your body's not doing the balance so well, then you have to try to do it for your body. And that's also why we give water, pills, and diuretics to try to help get rid. since again, the balance is off, the kidneys maybe aren't functioning so well, and they are part of getting rid of fluid, so we have to help everything along. TIPS is a procedure that can be done for people with ascites. It would help change the pressures in the veins around the liver to try to relieve it and therefore relieve the ascites. It's not always something we'll do for everyone. It's for some people, and for some people it works really well. But in doing that, in changing the blood flow, then we're also risking some of that hepatic encephalopathy, because now we're moving blood away from the liver in a way that it's not getting cleaned again. So TIPS is sometimes an option and sometimes there's a risk, and we would usually discuss that with the person before it's decided on. And again, it's not for everyone, but it can help if we're having a lot of ascites and the person's a good candidate for it. So varices, I jumped the gun before, but here's a depiction of varices, the blood vessels in the throat that are swollen, and it can cause varices elsewhere because all your organs are very close together and all their blood supply is very close to each other. So one change in one area can affect the others pretty easily because of their proximity. On the right there is a endoscopic picture. So during an endoscopy, that's what varices look like. I think it'd be better if you had a normal esophagus plus this one so you knew the difference, but basically everything that's very bumpy in there are these varicose veins. Like if you've ever seen someone with very varicose lower legs, really bumpy, that's kind of what the inside could look like in someone's esophagus. And this is one way to treat them. So this is a procedure we call banding. It's literally putting a band around them to try to kind of make a scar, which would help get rid of some of the vessel. And then the scar kind of helps push it in to keep it in place so that it's not bulging out. This isn't always needed. Most of the time we start with a medication called a beta blocker, so nadolol or propranolol. There's a couple others, but we tend to start with those. They lower the heart rate, and your heart rate helps lowering your heart rate helps lower the pressure in these varices, so they aren't bulging as much. So they're not as full of fluid because they don't have as much coming in. So in doing that, you can prevent needing banding, risking bleeding, and you wouldn't need to worry as much because they would deflate a little bit or a lot, depending on the person. So these are some of our treatments for varices, for esophageal varices. Okay, so who needs a liver transplant? Well, this is not a mixed group, so everyone here probably is someone who needs a liver transplant. Anyone with cirrhosis who has experienced decompensation, or as described here, a complication from their liver disease, liver failure, liver cancer, or other metabolic disorders that can't be fixed in the liver. So why is there a list? I mean, I'm sure we can all draw the conclusion here, but there's not enough organs available for everyone. There are a lot of people on the wait list, but not a lot of necessarily are taken off the list by getting an organ. So there's a discrepancy there in the numbers of those who need it and those who are offered or have the opportunity to have one. These are older now statistics, and they've grown since. But we had in 2010, 5,000 deceased donors transplanted. In 2009, 247 living donors. The living donor numbers have increased every year, which is great. Deceased donor, I can't remember the most recent ones, but things are improving. They've made some changes to the way things are allocated, and that seemed to have helped a lot more people get organs. So these numbers have increased since then for sure. And I believe you can get everything up to date as well online on things like the SRTR websites. They're very statistical. They give clear numbers of every institution and what they're doing. This is what we use to decide how we're allocating. There's regions. So the United Network for Organ Sharing has given us regions as to where organs are offered and distributed. And we're region 9. And you can see all the others here. And it's chosen by population. So, we're in a really densely populated area, so we don't span too many states. And then other areas have a lot to them. How can I be put on the list? Well, you have to do this. You have to listen to me and undergo a liver transplant evaluation. Need a transplant. That would be a really good reason to be on the list, right? Be healthy enough for the operation. That's something I always try to stress, is that we're doing this evaluation to make sure not only that you need one, that you're ready for one, but that you would survive a surgery and survive the transplant. Because why would we give it to someone who that would be the end, right? We want them to have a good, healthy life afterward. That's why we are doing this. So we want to make sure that everything up to then is going to be safe for them too. The last bit of the transplant is that the person will always need to take medications, because this organ is foreign to their body, and their body thinks anything foreign needs to get out. So the medications help prevent our bodies from rejecting the organ. And it is lifelong, because the organ itself is always going to have a different DNA. It's always going to be from somewhere else, but over time the body gets used to it, and we just keep it at a minimum far in the future. But at first there is a lot of medications, and that's something that has to be understood when getting into this whole process. And the list works by MELD. It's a big calculation there, and it has to do with your lab values, and it moves people up and down the list depending on how sick they are. MELD does not always reflect the person's symptom, like their feeling, how sick they feel or look to us. Sometimes it's not the best score, but it is what we have. And then there are exception points too. If we get there. Yeah, there we are. So MELD is not perfect, as I was saying. The MELD is expected to reflect, and it's the most objective thing we have, but it does not always reflect how sick a person is. And so we have options for points for certain conditions, and it's something that we apply for the person and hope to get. And then when a person gets points, then they keep that number no matter what their lab values show, which is good for that too, because then they still keep their chances no matter how sick or, well, no matter how healthy they are. If they got sicker than their points, then that's taken into strong consideration, because that's, significant. So someone with low MELD score, who we would also consider good for these options, could get living donor or extended criteria donations. Living donor is self-explanatory. It's coming from a living person. Extended criteria is some things outside of the norm, but not too outside the norm, that a person could handle, but wouldn't be considered a, completely, utterly, nothing completely wrong with it liver, that someone who's very, very sick couldn't handle a couple extra things going on with the liver. So it's extended criteria. So post-transplant, I believe we have a whole other workshop on this too, the long-term care, but immediately post-transplant, like we were saying, is a lot of medications. Over time, you will require lifelong medical care, all the medications and visits, blood tests. And liver transplant is a treatment and not necessarily a cure for most things. You can get fatty liver again if that was your original reason. We can cure hepatitis C, but you can get it again. So, you get it cured, and then you want to stay away from whatever gave it to you. Hep B is a lifelong thing. PSC can come back. Autoimmune is ongoing. So it is a tool in our toolbox for a person to improve and get better, but it will always require us and lifelong maintenance. If any of you have the nurse practitioner Margie, one of her things she always said to me, and I'm pretty sure she says it to everyone else, is that this is a lifelong relationship between your healthcare provider and you after transplant, till death do us part. It lasts longer than some marriages. So that's how we will come into this thinking about it, is that it's always going to require care, not always care all the time. Sometimes it gets more extended and it gets to a more normal routine and we see you less often, but it's definitely something that's lifelong. That's the main word there, is lifelong. And that's the end.